Let's talk about sepsis. For as long as we've practiced medicine, it's been one of our deadliest, most relentless challenges, a brutal race against the clock. So what does the future of that race look like? Well, today we're going to decode the brand new 2026 international guidelines to see exactly how the fight against this global killer is changing.
To really get why these new guidelines are so incredibly important, you first have to understand the sheer scale of this problem. Every single year, we see 49 million cases of sepsis worldwide. Just let that number sink in. That's like the entire population of a country like Spain getting hit with this life-threatening condition annually. And out of those 49 million cases, this next number, this is the tragic human cost. 13 million. That's how many people lose their lives to sepsis every year. It's just not a statistic, it's a global crisis. And that's exactly why getting these guidelines right is quite literally a matter of life and death.
Okay, so we've seen the staggering numbers, but what is sepsis really? Let's get into what's actually happening inside the body that can turn a seemingly simple infection into a full-blown medical emergency.
So here's the official definition, but I think the best way to think about it is like this. Imagine your body has an infection. It calls in the fire department, that's your immune system, to put out the fire. But with sepsis, the fire department's response is so overwhelming, so out of control, that it starts destroying the house itself, your own organs. And that's what makes it so incredibly dangerous.
In the race against sepsis, every single second counts. And that race officially starts the moment we spot the signs. This means that early and accurate detection, it's everything.
Now, I know this slide looks a little dense, but the most important takeaway is right there in recommendation number 1. The guidelines make it crystal clear. Fighting sepsis isn't just about one doctor's heroic effort. It's about building a system. Hospitals are now being urged to have formal, standardized programs in place for both sepsis screening and quality improvement. It's a huge shift from just reacting to being truly prepared.
So what does that system look like in practice? Well, this brings us to a really crucial change in recommendation 4, which is all about comparing different screening tools. Over on the left, you've got tools like News and Muse. These are now recommended because they have high sensitivity. Think of them as a wide net, right? They're designed to catch as many potential cases as possible. But then look at the right. A tool called Q-SOFA is now recommended against being used all by itself. And why is that? It has lower sensitivity. It's like a net with bigger holes. It can easily miss patients who are in the very early stages of sepsis. The message is pretty straightforward. When it comes to screening, it's way better to be safe than sorry.
But here's a super important reminder, coming from recommendation number 5. While all these screening tools and blood tests are helpful, they don't just spit out a simple yes or no answer. Sepsis is and always will be a clinical diagnosis. At the end of the day, it's up to the doctors and nurses at the bedside to look at the whole picture, the patient, the symptoms, all the data, and make that final critical call.
Okay, so a patient has been flagged by the screening system. The team suspects sepsis. Now the race truly begins. The clock is officially ticking on what is arguably the most critical hour of that person's entire hospital stay. This is where speed and precision absolutely save lives.
And here they are, the 3 non-negotiable first steps, pulled straight from recommendations 7, 10, and 16. Number 1, get blood cultures to figure out exactly what germ is causing the trouble. 2, give IV fluids to support the patient's blood pressure and keep blood flowing to their organs. And 3, start antibiotics to attack the infection head-on. These 3 things have to happen, and they have to happen fast.
This flowchart here shows how the guidelines have actually built in a pretty smart, nuanced approach to urgency. If you look at that top path, if a patient has definite sepsis and is in shock, the directive is unambiguous. Antibiotics immediately, within the hour, no questions asked. But if you follow that lower path, if sepsis is only a possibility and the patient is stable, there's a 3-hour window. This gives clinicians a little breathing room to confirm if there's a real infection, which helps prevent the overuse of antibiotics while still acting quickly. It's all about balancing aggression with precision.
Now, about those IV fluids we mentioned. The guidelines get incredibly specific here. Recommendation 10 suggests giving 30 milliliters of a crystalloid fluid for every kilogram of a person's body weight. Basically, it's a solution of salts and water that's designed to rapidly boost fluid levels in the body. The goal is to quickly pump volume back into the circulatory system and get that life-giving blood flowing back to those oxygen-starved organs.
All right, after that initial frantic hour, the strategy starts to shift. Once the patient is stabilized, the battle moves to a new front.
Now it's all about supporting the body's organs while hunting down and totally eliminating the source of the infection itself.
So what exactly is source control? Recommendation 23 is all about this. See, it's not enough to just pump a patient full of antibiotics. You have to shut down the factory that's producing the infection. And as you can see here, that could mean a surgeon draining an abscess, or removing dead and infected tissue, or even just taking out an infected line or some other medical device. Getting rid of the source is absolutely fundamental.
Of course, in modern medicine, we're facing a whole new kind of challenge. What happens when the infection is caused by one of these so-called superbugs that are resistant to our most common antibiotics?
The guidelines tackle this superbug problem head-on, with a really smart, risk-based strategy. The basic idea is simple. Don't use your biggest antibiotic guns unless you absolutely have to. For a low-risk patient, you avoid the heavy-duty drugs to help prevent more resistance from developing. But for a high-risk patient, say someone who's been in the hospital for a long time, you bring out the big guns, those targeted, powerful antimicrobials, right from the very beginning. It's all about matching the weapon to the threat.
And what if those IV fluids just aren't enough to stabilize a patient's dangerously low blood pressure? Well, that's when vasopressors come in. As it says in Recommendation 12, these are powerful medications that basically squeeze the blood vessels, which helps to raise blood pressure and make sure that vital organs keep getting the blood flow they desperately need to survive.
And this brings us to what I think is one of the most important new areas of focus in the 2026 guidelines. Because the fight isn't over when the patient is discharged from the hospital. For so many survivors, a whole new battle is just beginning.
And really, this section is probably the biggest philosophical shift in the new guidelines. For the first time, they formally recognize that the fight doesn't end when you walk out the hospital doors. The focus is now on recovery as a marathon, not a sprint. The guidelines are calling for structured, long-term support for the physical, cognitive, and mental health challenges that can stick around for months or even years after sepsis.
So what does the support actually look like for a patient who's finally going home? Well, the guidelines lay out a pretty clear plan. It means doing a comprehensive review of all their medications. It means making sure their family doctor is fully in the loop. It means screening for real-world needs, like financial or social support, and then actively connecting them to follow-up services. It's really about building a safety net to catch them after they leave the hospital's care.
So, what's the ultimate takeaway from all of this? You know, for decades, the goal was simple: survival. But these new guidelines, they raise the bar. They challenge all of us to answer a much more profound question. As we get better and better at surviving sepsis, how do we ensure we get better at living after it? This focus on survivorship isn't just a small update. It really marks the next great frontier in the long, long war against sepsis.